Pleasure to introduce our next speaker. Dr. Jerry Grant is a professor of neurosurgery. He is a co-director of the Stanford Brain Performance Center, and he is the director of the Pediatric Concussion Clinic. We are going to upload his talk here, and he is going to be talking today on updates in the management of pediatric concussion. Thank you. Thanks, Jerry.
Well, great. Nice to have you here. It's really special getting this together. I congratulate Angela and Jam. Jam, where'd you go? It's being interviewed. This is amazing to bring their teams together and all of you in the room to talk about this topic. Because it's so complex for these kids, that's why Jam and Angela gave me 4 hours for this talk. So it's going to take us a while to get through this, but there's wine coming through in a little bit. Don't worry. I'd like to highlight some of our team here. I mean, May, just raise your hand, May from our nurse practitioner, neurosurgery, and Anna up there in the back, who's our concussion NP that leads our team, and Rachel next to her, a vestibular physical therapist. Dr. Grebe, still here, orthopedic, seeing concussions with us too. So there might be others, and raise your hands if you're here, but on the clinical side. But it's really wonderful that all of us are here to talk about these topics, particularly for kids. For me, this came about really from my time in the Air Force when I was deployed, taking care of soldiers in Iraq, taking care of blast concussion. We didn't really know what that meant back then. It was a new diagnosis we had to try to figure out in the field with really not much being written on it back then. This is 2005, not that long ago, when the book really has not even been started on this topic. We'll talk about a few things. We want to highlight just some questions to get us started. So Robin, for example, field hockey player, suffered a concussion, had quite a bit of persistent headaches, otherwise doing well, back in school. The big question is she should be cleared. So headaches still persisting, but ready to go back. Everyone want to clear to go back? Couple, all right?
Any other symptoms?
No, just headaches. Yeah. So something we face every day, right? Our headache's something that is going to block us from getting these kids back to play. I know what Jam will say here. How'd the interview go, Jam? Good? Good. So take Bobby, for example. Third concussion playing football, imagine during the season. Symptoms resolved 5 days. Of course, the state championships are this weekend, right? 3 days from now. Should he be cleared to play? Anybody? What bothers you here? Third concussion, right? Does that matter? This is really critical to think about these things. Think about common reasons for someone's not getting better. What's least common to think about? Lack of sleep? I'm sure that was highlighted this morning. Too much screen time. Almost every parent asks me, with the kid present, how much screen time is he or she allowed? And of course, we have no good answer for that. And I'm giving an answer, and they're cringing, the parent, of what I'm saying. Early return to exercise. Is that a reason for not getting better? Quite the opposite, right? Or dehydration, definitely something that we can do something about. More concussions happen in the NFL than high school. True or false? False. We started with the NFL this morning. But the problem here is youth concussion. Many more happening on the youth level. We highlight what Dick and P are there doing. Unbelievable work for education and prevention for our high school and middle school kids. That's the biggest gap we have, and please go up there to their booth and look at that VR because it's absolutely incredible. That's our future, how to reach these kids in terms of so they understand the power of what we're doing and the impact. Over 90% with a concussion get better within 7 to 10 days. True, right? I mean, most kids do well, so we're talking about the tip of the iceberg, these kids that aren't getting better. That's what we see. Our concussion clinic is a little more complex where it's almost 2-hour visit, like on the adult side, and Jam's model that we really highlighted that takes a long time to really better understand, are these kids ready and why they're not getting better. It's a long time in that clinic, very time consuming, not worth it for the kid first week out. That's not necessarily what that clinic's about. But it's critical with this complex return to play decision making This is where we struggle on these kids. And we know the definition problem. We love to use Mike Zina's work that he highlighted about imaging. I wish we had great MRI biomarkers to use in the acute setting, but we don't. We define concussion often by a CT being normal, but we don't know about MRI yet, right? We're still learning. We don't do them often in the acute setting. In the military, we did it even months to years after the injury. Sure, we find stuff, but what does that mean? And we have this 15%, this miserable minority that have these persistent symptoms and aren't getting better. So a year out, do we call that post-concussive? Is that still the same disease? And when I worked with the DOD on their PTSD, TBI groups for almost a decade, we struggled with that issue. The PTSD symptoms overlap almost completely with post-concussive symptoms. We can't tell them apart, but does it matter? It probably doesn't. So we really try to break down those barriers and just treat these people. We talked about the forces, there are things going on with acceleration. We highlighted that we don't necessarily have to hit our head to have a concussion. We know the whiplash plays a big role. But we can see concussions, of course, across all sports, right? The CDC will be cycling far above any other sport, but we rarely hear about cycling, right? It's always football, soccer, these other sports because of what's highlighted in the media. Even bowling's on this list. Someone from Jersey, like myself, bowling is on a concussion list. If you look at it, it's unbelievable. Well, I don't know what happened. Jam, you're a bowler. What do you think? You're in New York. You're not happy you came back. Get your fingers out of the ball. But clearly we still have trouble. And I bring up this slide because when we clear someone, it's always a question of the parents of, well, can they play this sport but not that sport? We're not in that game. If I'm clearing them, they're cleared for contact sports. I am not writing out, you are cleared for football. Whose decision is that? It's the parents and the kid to decide. And I really put it back on them. Do you really want to play football? Do you want to play soccer? They have to have some say in that. All I could say is you're cleared in some best sense that we know, but they have to decide what kind of sport they're willing to take and what risks they're willing to accept. So we don't have good objective measurements, right? Across the military, across sports, we could see concussion across the room. We know what it looks like, right? We spent the morning talking about it, these signs and symptoms, what Angela sees in the emergency room. They all look very similar at some stage post-concussion. Are they all equal? And we used to really take these apart, right? Remember the DOD and the NCAA didn't quite get in the same room together for a long time. These are similar injuries with probably similar physiology that's happening. It's very hard to prove that, but they all look very similar. And I'm a big believer that we really have to come together to be able to make some headway. Finally, we have some funding options to fund this kind of work for concussion, mild TBI, across military soldiers and athletes and age, which is fantastic. And it's a credit to many of you in the room that are doing this kind of work. If you think about concussion, right, this is the problem, right? The high school and youth, way above, of course, every kid thinks they'll be here at any professional sport, but this is the problem. This is what we see in our practice on the kids. Of course, in terms of rate of concussion, you're going to see a lot more in football and soccer. This time of year, hands down, no question, girls water polo, for me, is off the chart. I don't know why these last couple of years, but it's just taking over in terms of the number of injuries we see. And Anna can attest to this the last few weeks alone. We're just seeing so much in terms of water polo. And there's many reasons for that were highlighted in the VR stuff that we're doing, I think, for education. This is so critical to understand the game and what's different about water polo, the refs, the understanding of injury, a lot happening below the surface of the water that's not detected unless you have underwater cameras, things like that as an example. But sure, we see these injuries across sports. We dwell a lot on soccer in terms of girls versus boys. I don't know if Michael talked about some of the studies we're doing with lacrosse now. One of the first sports where we have girls and boys matched up by gender and age. That's really important because a lot of what we're doing is football because some of the mouthguard work we do, but it's very nice to be able to compare the same sport Really, really neat data. We're learning to really start getting to the tip of the iceberg of that. We see a lot more girls' injuries, we think, at the same age, and is that the reporting issue? Is that the neck being weaker at the same age? We don't know, but there are definitely concerns about the underdevelopment of the neck. And Jan probably highlighted this a bit maybe this morning. Like the ACL tears happening, in the adolescent young women, no different in the neck. There's something happening at that young age that we don't see, and then the boys you start seeing a little bit older. But they're all serious, right? We don't want to hide it. We understand what these injuries look like. They may look very different of one kid to the next. We used to treat them all the same, right? We talked about subtypes this morning, in terms of really start to dissect out now what kind of concussion are these and really get to the heart of how to get these kids better. We look at all their symptoms, like we just talked about, the dizziness just highlighted, the headaches. I mean, these are amazing talks to think about strategies when you're really trying to localize, one specific aspect of their recovery that's not getting better. The one we've ignored is the sleep. No question this is affecting these kids' performance during the day. This has been proven over and over on neuropsychological testing, but very hard to study, particularly in the kids. But we ask so much about sleep now in terms of, how much more do we need to do? Is just melatonin, or what else do we need to do? But no question, getting them back to exercise sooner helps their sleep, makes a very big impact in terms of how they're doing during the day. We use different things on the field. There's a lot of work, if you look out there, of sensors and work being done. Very exciting to understand what's happening on the field. These are acute measures. For the 49ers, when I'm there, they have one way of doing it. We're in different high schools. Each school has their own way of how they clear these kids. A little bit different at each school, a little different flavor. Is one better than the other? We have no idea, right? And we're not meddling in that too much right now because we just don't understand enough to know one versus the other. We really want these kids to play sports safely. We're always the grim reaper, when they come see us. I mean, these kids really do not want to see me. They like Anna, but they don't want to see me. Rachel, or May, but they don't want to see me at all. So this is our problem. Let's start thinking of those 2 hours of really what type we're looking at. How do we rehab some of this 3 months out? Why is this kid not getting better? That's where the focus is now in terms of being much more aggressive in their rehab. Stanford just hired, for example, a optometrist, Dr. Roberts, focusing on convergence problems in concussion. Amazing for that, because that's an area that we've had a big gap of how to deal with that and how to get that funded to get a kid to be able to go there and get rehab for that. It was very challenging to do that. Why the kid can't read? Why is that? Is that a convergence issue, or is it something like talked about this morning, probably with the smooth pursuit? This is really challenging to think about, and we don't want to treat them all the same. I think this has been highlighted a lot in terms of this early return to exercise, which has now been studied in a randomized way in the kids. We're no longer just sitting in a dark room doing nothing. We try hard to get these kids back to school as soon as we can. We know that pays off. Even a small dose is better than nothing in terms of getting them back to some degree. But not a lot of science over the years to really, help us with that. In terms of what we're doing on the field, we work closely with many of us here in the room to highlight with Dave Camarillo's mouthguard technology, which has come a long way over the years to really get validated understanding of what's happening on the field, 3 different forces of acceleration, and really try to recreate what happened, for some of these injuries. If you look at some of these, like on the Stanford athletes we do, you can now go back with our material engineers and do the finite element work and recreate exactly what happened based on that mouth guard, which is fixed to your skull base. We could tell if that kid's mouth was open or closed during the injury, which probably matters, we think. That's the whole anticipated or unanticipated hit. We can look at the brain and kind of what happened. This will scare you to look at this, but this is kind of a recreation of what happened on this particular hit. And what's exciting is to also have imaging on some of these kids to really start thinking about, well, does this make sense? where a lot of the forces, say in this player, told us that they were all deep, right under the falx, which is a pretty stiff structure of the two sides of the brain, of a lot of shear that's happening in the corpus callosum right there. This is an anatomic example to show that corpus callosum. So this all does seem to matter. These are deep injuries. They're no longer thinking about little contusions up on the surface. But to bring this whole story together, to know what happened on the field, to have imaging, we have symptoms of the phenotype in that kid, we can really start pulling this together. And I think that's where the future is, which is going to be very exciting to think about. We're now doing some work in Europe with our collaborators of blood-brain barrier where we give contrast. You know, if you have gadolinium that you have with MRI scans to look at leakiness of the blood-brain barrier. Blood-brain barrier normally is a good thing. Hopefully your barrier in this room is quite tight. You don't want to have a leaky barrier. But after trauma, serial trauma, it might set up for a lot of leakiness that happens, which may predispose you. Think about subconcussive hits. Sub-threshold, meaning subclinical hits that happen over and over in practice. Are they setting themselves up for more leaky injury? These are tough studies to do in the United States because of giving gadolinium, contrast, not so trivial. And Michael keeps telling us, oh, can't do that, can't do that. Luckily in Europe, in Ireland, our studies there, we can get away with this for rugby and now for some of the martial arts teams. So we're learning a lot from this of doing pretty acute MRIs in the first 48 hours after injury. But we might hopefully get to this point where we think about certain thresholds of tissue strain to get all the way back to what happened on the field to say, okay, maybe this player is over this threshold. The difficulty is the science isn't there yet, because we're still looking at a group level. We really got to think about each player as an individual. Your threshold might be very different in terms of sustaining a concussion. These forces on the field might take very little. Like that kid I talked about in the beginning with 3 concussions. One might have been enough, right, if it took him 6 months to get better. So we have to kind of cater this on an individual basis because, yes, one could be enough. 1 year recovery, is that worth it to send that kid back to a contact sport? I would say no way. Clearly that kid's more vulnerable in some way. We don't do genetics usually for ApoE. We're not, getting into that as much. But we know based on our Leisted law, which is something that is very close to my heart. I trained in Seattle where this kid was treated at Harborview, where he was hit on the field, of course, went back to play, got hit again, and got a bad subdural. What's amazing, this kid was operated on, terrible 6-month course, year-long recovery, got better enough to sit in front of Congress and tell them about his experience of how important it is for whole understanding the second impact syndrome. It took him to change the law in 50 states. I mean, pretty impressive in terms of why did it take so long for one player to make that happen? And these principles, right? Education. All the education that we're doing is critical. If you miss this, nothing else is going to matter because this is all the prevention. Otherwise, it's just after the fact. So these players have to be engaged, the parents. You got to get them out if you're worried. And that was talked about, I'm sure, in the panel this morning. I'm sorry I was in the OR, I missed it. But I'm sure this is, understanding of delayed symptoms, and you may not know right then. You got to get them out. And then how to clear them. Who can clear them? Any practitioner can clear them. It doesn't have to be a neurosurgeon, right? It can't be. It's not practical. I mean, we got to let these kids get back to play as soon as it's safe, and we got to make sure we don't miss the ones that really shouldn't go back to play. So really, we have to be open to that. But there's a little fine print here that everyone who clears these kids have to have education about concussion. That's not policed in any way, right? So that's a really important gap, I think, that we still haven't closed. This is the old slides about return to play. When they're in my clinic, to clear them, it's going to be at least, 10 days almost. By the time they come to see you, if they're symptom-free, to ramp them up, are they really ready to go back? They're going to miss that next game. And we often make that clear right away, just so they don't have to hedge about that. It's about the game after that we're really thinking about, and that's important. Do they have to be back to school before they play? Well, most of you are nodding, oh, it makes sense. Now, many of the time, this does not, it's an afterthought. Are they okay in school? Or did their grades drop? Are they actually able to pay attention? Are they able to concentrate? Are they going through a full day of school before they've been cleared to contact? You'd hope so. But unfortunately, this is a slippery slope. They might be a little bit back, and they're back to a club sport because it's away from the school, right? You can't be back in the school sport yet, but you could be in a club sport, okay, because there's no visibility of that. So we have to be very careful with how this is applied. Cognitive rest, 3 days versus 5 days. Who do you think did better? The 3 days. Get them back, doing stuff, earlier than we used to think. We think it's important to engage them. We're not going to hurt them by doing that or prolong their recovery. Early return to exercise. This is a recent trial in JAMA Peds, right? It just came out. Small numbers. I mean, it's sort of 50 and 50, but it still is, I think, really important. It was across gender to look at earlier versus later return to exercise versus kind of stretching and doing their own thing. Hard to police that, of course, but who did better? Those getting back to exercise. Whatever this means, sub-threshold, we don't know what that quite means yet. Always how much to push them, and I leave that up to Rachel to say, is it safe? What can they do from a physical therapy perspective? And what's the risk? Repeated concussions are what we're worried about, right? We're just talking about the military, and the average IEDs that they used to sustain, somewhere above 5 for sure, 5 to 10. And that was a common thing. In the sports arena, we hate that when they say this is their 5th concussion. What happened after 3? The worst is the ice hockey player, a month ago, remember, Anna, who was still playing. Dad's the coach, okay? 6 concussions. That should never happen anymore. And this is in Palo Alto. What are we doing? So we have a long way to go, I think, in terms of, the education. And they're participating in multiple sports. Does that create higher risk? Clearly the kid that had a concussion in the same sport 3 times, we're worried about that kid as opposed to maybe something random that happened. That may be a little less so, but we treat them the same. What about, I hit my head at age 6 and fell off the swing set? Does that count? I mean, there's a lot of questions these parents. This week we had a parent give a concussion resume. The kid had a resume of all their concussions in color, beautiful. Resume to think about all the history of the concussion, everything that happened, symptoms, treatments. I mean, this is where we're going, with this. We all want to avoid this, right? And the CTE talk to come next will scare you, but this is what we're trying to avoid, is what we need to take care of in the operating room. This is too late, right? We don't want to get to that point, and we wish we could diagnose it earlier. This is thinking about imaging. This is a group in Boston I worked with in the DOD PTSD group for a while, looking at hockey players. Now, it's not good, as Michael will tell you, to have dots in your head. Some of you might. I'm not going to, I'm just saying. But, these small areas of microhemorrhage, it's not a good thing. Now, in hockey, maybe this is more common, but what's interesting in this study that was done in Europe, these are all asymptomatic players. These aren't players that said, I got trouble. These are players just getting MRI scans. So maybe we should do more of them, and I'll be curious what Michael thinks about that. So in the end, think about these red flags. These worry me the most. Prolonged recovery is a real problem, meaning you had 1 concussion, symptoms lasted a week, 2nd lasted a month, 3rd, maybe 6 months. Beware of those. Something's wrong. Either they didn't recover from that first one, and we sent them back too early, or they're not resilient. And I think that's where, at least I think the field is going, to look at resilience or lack of in the subacute and chronic population and get much better biomarkers for that time frame, because that's the hardest for me to interpret in the clinic. Shorter intervals between injury, big red flag, right? 2 stuttering concussions in a row that happened. Something's wrong. We got to get them out, whatever reason, but there's something wrong. Subsequent concussions, while still symptomatic, shouldn't happen, right? Hopefully we took them out, but unfortunately that does happen to him or her, in whatever sport they're doing. And progressively less force required to cause a concussion. That's the kid that, she was hit on the field hockey, like Robin was, doing fine, hit her head on the doorknob or something, symptoms right back to the beginning. You know, you hear that a lot, right? What happened? Or the kid was fine and then got busy at school, all the headaches came back. Is that kid really ready for a contact sport? When all the inputs coming in, they can't quite sift through that. They can't triage that. How do we pick out that kid? You know, I would beg to differ that I don't think anything we have now can really tell that apart yet. So that's where I think we need to work on with these kids in terms of better understanding. I just want to close with this slide that, you know, we're doing this now through many different schools and ages. A lot of the work that I'm sure Michael talked about that's happening here around Stanford and with JAM, looking at all the Pac-12. We work very closely with USC, doing a lot of this imaging work. We have a consortium to look at mouthguard data across many universities now to try to understand that. This goal goes into a FITBR database like Track TBI, which is great, to put mouthguard data in that. It didn't ever happen before. And then the Toby, who's a philanthropist that has been we're so excited to work with because he's really helped fund this initiative at the high school level. And it's local, to really understand in the high schools, to get all these metrics in place and prospectively try to get a better understanding what these kids are going through at various ages, various weight, various positions, different levels of play, different experience level, JV, varsity, looking at the mouthguard data on the field across, you know, we had over 100 kids last year enrolled. Fortunately or unfortunately, not good for the players is that we see so many more concussions at the high school level. I mean, the engineering team they're so busy because in the college level, you don't get that many, which makes it hard to do research, right? It's a good thing. Maybe they're underreporting. Could be an issue. But that is a problem from a research perspective is you're collecting so much data, and if you're only looking at 5 concussions, it's that whole tip of the iceberg thing. But in the high school, we're getting so much more data, you know, to look at. It's quite blinded, and it's I think in a great way from a statistical perspective that we won't know what's really happening until we uncover it 2 or 3 years later. And we're not meddling into who goes back to play, again, like I talked about. But to be in the high school level, I think, is very important. There's so much happening at that age, 13 to 17, with myelination, pruning, synaptic plasticity in the brain, particularly at that age, I think is an incredibly vulnerable age. Why the kid with ADHD takes twice as long to get better. You know, lots of things that we're doing to try to understand this. And being in the high school, you know, there are tough studies to do, very expensive to engage with these schools, but we've been so happy to work with them, and we thank Toby, Tad and his wife Diane for really funding that work, and also funding the VR work that Pia and Dick are doing. It would not have happened without him, and we're indebted to him for that. I think I'm out of time, but thank you for your attention. So.